Case presentation: a 14-year-old male with a history of obesity hypoventilation syndrome presents to the emergency department with worsening fatigue, mild cyanosis, and dyspnea. His mother reports that he has been increasingly drowsy over the past 24 hours. On initial assessment, the child is hypoxemic with an SpO2 of 85% on room air. He is tachycardic and mildly hypertensive, with no signs of acute infection. Clinical course: oxygen supplementation via nasal cannula at 2 L-min is initiated, improving his SpO2 to 92%. However, over the next hour, he becomes increasingly lethargic, prompting further evaluation. An arterial blood gas, ABG, reveals a pH of 7.30, PaCO2 of 65 mmHg, and PaO2 of 65 mmHg, consistent with acute on chronic respiratory acidosis and hypercapnia. Discussion: this case illustrates the potential for a mild rise in PaCO2, hypercapnia, following oxygen supplementation in patients with chronic respiratory acidosis. The underlying mechanisms include: 1. Loss of hypoxic pulmonary vasoconstriction. Increased oxygen levels can lead to dilation of pulmonary vasculature, worsening ventilation-perfusion mismatch. 2. Reduced peripheral chemoreceptor stimulation. High oxygen levels decrease the hypoxic drive to breathe, reducing ventilation. 3. Haldane effect. Oxygen binding to hemoglobin reduces its affinity for CO2, increasing plasma CO2 levels. Clinical management: oxygen therapy should not be withheld in hypoxemic patients, as maintaining adequate oxygenation is critical. However, in this patient, close monitoring was necessary. Given the progression of hypercapnia, non-invasive positive pressure ventilation (BiPAP) was initiated to support ventilation and reduce PaCO2 levels. The child responded well, with improvement in mental status and gas exchange.